Very good morning to all of you. We warmly welcome for today's CPD program webinar organized for GMOA members by Government Medical Officers Association and Society of Health Research and Innovation. Let me get you the same housekeeping rules as usual. The webinar link will be available from 9 a.m. to 9:50 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. The link for this post at the chat box end of the webinar. I would ask you to kindly switch off your video and mute your microphone to avoid any interruption during the webinar. There will be a Q&A session at the end of the webinar. I would invite all of you to type any of your queries into the chat box to be discussed at the end of the session. Without further ado, I would like to introduce you today's topic, which is practical approach to vertigo and dizziness. Now I warmly welcome today's distinguished speaker, Dr. Daminda Duminago Arachi, Consultant ENT Head and Neck Surgeon, National Cancer Institute, Sri Lanka, to start this program. Over to you, sir.
Thank you. Okay, thank you very much. Today we are going to discuss some practical approach to diagnosing vertigo and dizziness. I'll first discuss about some practical definitions. Now, vertigo is defined as an illusion of either oneself or the environment rotating. Now, you need to have this sense of rotation to name it as vertigo. So, always look for this particular symptom. You need to have feeling of rotation to decide it's vertigo. And when it's real vertigo, it's usually due to vestibular problem, either peripheral or central. Now, we have dizziness is another term which is defined as impairment of spatial perception and stability, which is an sort of umbrella term. Now, you have disequilibrium or imbalance, motion intolerance, or oscillopsia, which we are going to discuss at the later part of the discussion. And even vertigo comes under the umbrella term of dizziness. So when you say dizziness, it's more of a general term. Now, when you take a history from a patient with vertigo or dizziness, therefore, you need to first understand the real problem. Now, you need to understand the nature of the problem. That means whether it's vertigo, whether it's dizziness, or whether it's something else, something like episode of loss of consciousness, or fit, or something completely different. So, when you are sure that it's vertigo, when you make sure that it's vertigo, then you can go into the latter part of the history. But the next thing, the next important aspect is the pattern of the problem. Now, these things, these symptoms happen in a pattern. So, we have about 3 distinct patterns in our history, and this particular pattern makes the basis for the current classification of vertigo and dizziness. So, you can have a single episode, a big single episode. Sometimes the single episodes last for about a couple of days, and then you have multiple episodes, and then you can have waxing and waning sort of chronic dizziness. So you should be able to put your patient into one of these categories usually, and then go on with further examination to rule out or to come to a differential diagnosis and then diagnosis. Now, first we'll discuss acute episode, acute single episode. We are talking this, and this is not the commonest form. The commonest forms are like the multiple episodes like Bpvc, but we are discussing acute single episode for you to understand a bit of anatomy and bit of physiology about vestibular pathophysiology. So suppose a patient get admitted to medical casualty ward. Now, this is the common scenario where a patient with big single episodes get admitted to medical casualty ward in the night with severe vertigo, big episode lasting for a few days. And when you examine the patient on the next day, the patient is still vertiginous, and the patient never had similar history in the past. So we'll see how to sort out this patient. Now, when it comes to a big single episode, one single episode, acute single episode, the causes could be peripheral or central. The peripheral causes are more or less benign, like vestibular neuritis or acute labyrinthitis. We'll discuss the difference between the vestibular neuritis and labyrinthitis. They are not the same. They are due to vestibular pathologies, peripheral vestibular pathologies, and the central problems like cerebral hemorrhages or brainstem infarction. They are more serious. So our aim in this scenario would be to exclude more sinister cerebral or brainstem pathologies to save lives. So the single episode can be, once again, peripheral or central. No, the issue is how to differentiate. Now, there are three ways to differentiate, and there are a lot of ways, but there are three important ways to differentiate. Now, the peripheral patients, peripheral vertigo patients, will have what's called peripheral vestibular nystagmus, whereas the central patients will have a central nystagmus. Now, head impulse test, we'll be discussing that later, will be positive in peripheral patients, but it will be negative usually in central patients. And there's something called skew deviation, which is negative in peripheral patients. The skew deviation will be positive in central patients. Skew deviation is basically a neurological sign. So we'll come to each segment slowly. So for us to understand this nystagmus, the first differentiating feature is peripheral vestibular nystagmus. To understand the nystagmus, we'll need to understand a bit of vestibular anatomy and physiology. It's going to be a very brief introduction. So this is the vestibular system. You have this cochlea and then the vestibular apparatus. Now, the vestibular apparatus has three semicircular canals and the vestibule in the middle. So we'll be discussing mainly on semicircular canal for the time being. Now, in the semicircular canals, you have what's called perilymph. Now, the perilymph is a sort of a inertial, obvious, like any fluid. So when you move your head or when you rotate your head, the inertial action will rotate the perilymph into the opposite side, like in this short video clip. So perilymph movement is opposite to the head movement, head rotation. Now, at the end of each semicircular canal, you have a swollen end called ampulla, and inside the ampulla, you will see now there are three ampullae, like ampullae, because you have superior canal, lateral canal, and the posterior canal. So this is the superior canal, and this is the lateral canal, and the posterior canal. So each canal has a swollen end, and in those swollen ends, you have what's called cristae. Those are the sensory organs. Obviously, you have hair cells there, and the hair cells are embedded in a gelatinous layer. Now, this gelatinous layer moves left and right, or to one side or the other, depending on the fluid movement stimulating the nerve endings. So this is a diagram showing a head. Now, these are the lateral canals here, one and the other one. So the lateral semicircular canals are like enlarged here. So the heads rotate into the right side, and the endolymph moves, perilymph moves to the opposite side. Therefore, that's the perilymph movement, and then that will stimulate the cristae on one side, and that will stimulate the nerve endings on that side. This is the stimulation here, and then that will drag basically the nerves crosses and then drag the medial recti and lateral recti on the opposite side, and thereby dragging the eye to the opposite side. Now, and the opposite happens on the other side, so that side get inhibited. Therefore, that will allow the above movement. So that will facilitate the above movement. So this is called vestibular ocular reflex. Now, this is a normal phenomenon. Now, you have vestibular ocular reflex when you move your head to one side, the eyes move to the opposite side in the similar manner, and that has to be there for you to have a stable visual environment when you are moving about. So this is the vestibular ocular reflex, the stimulator side and the inhibitory side. So it's a standard typical reflex arc. So this is the normal vestibular ocular reflex. So when you move your head to one side, the eyes move to the opposite side. This is just a bit of an animation. And then, so we'll see what happens now when you have vestibular paralysis. Now, in this case, the left side is paralyzed. So there's no impulses coming from the left side. However, there are impulses on the right side. So the right side now acts as a sort of a stimulated side, therefore, relative to the left side. And now the eyes will move to the opposite side. Now, this happens even without head movement. Now, here there is no head movement. The patient doesn't move the head like this. The patient is static. Or even when the patient is just staring at you, the eyes will move to the opposite side. And the brain doesn't like this. The brain, what does is like the brain gets the eyes back to the midline. But the hyperstimulation remains. So therefore, the eyes will go back to the opposite side, but the brain gets it again. So it's the brain action, which is called a corrective saccade, is very fast. It's something like this. I'll just show you, play the video clip. Try whether it works. Yes, it's something like that. So the eyes go slowly and comes back, go slowly and comes back. The slow component is not that slow in this animation. However, this is what happens. The fast component is the one which we detect normally. So the fast component is to the right side in this case, and it's away from the paralyzed side. So the nystagmus beats usually to the opposite side of the paralyzed side, or it beats away from the paralyzed side. So fast component is the one which we normally detect. So we'll see. Yeah. So this is nystagmus. So I'll just play it. So the fast component is to the left side, and therefore it has to be, the problem has to be on the right side. It has to be the right-sided vestibular failure or right-sided vestibular paralysis in this patient. Now, when you now this nystagmus is a jerk type of nystagmus. It's not a pendular type of nystagmus or a sort of a seizure or what, some sort of a different one. Now, this is a very jerky or sawtooth type of appearance. Now, you can detect or you can record nystagmus by doing a video nystagmography. We have facilities for those in Sri Lanka in a couple of places. We have here one at Anuradhapura, and then we have one at Vikramarati here in Colombo. So we have nystagmography. So when you do this, when you do that chart, you get a sort of sawtooth-like appearance. So this is one characteristic feature of peripheral vestibular nystagmus, and it beats away from the affected side. Now, there's a second important point. The peripheral vestibular nystagmus, the velocity of the nystagmus is more, or it's great when you look at the quick phase. Now, you saw in the previous video clip, it's beating to the left side. So we'll see what happens when you look at the left side. So that's at the midline, and then you look at the right side. But when you look at the left side, it becomes more prominent. So this is characteristic of peripheral vestibular nystagmus. So it's seen more towards one side. It beats faster on the fast beating side. The velocity is great in the fast beating side. So it is very important. So peripheral vestibular nystagmus is a jerk nystagmus, and its velocity is great when you're looking at the fast beating side of the quick phase. Now, this is in contrast to central nystagmus. The central nystagmus could be pendular, or it can have other waveforms. Now, for example, so this is a pendular waveform. It's like a pendulum. So if I try to play it, yes, it goes up and down. It's pendulum in a sort of a vertical plane. It's not a jerk. It's not having the sawtooth appearance. Right. And this is a different one. This rotates. So it doesn't have a sawtooth appearance. Just try and play it. One second. Yes, it just rotates. The patient is in a sitting position, the eye rotates. So it's not peripheral vestibular nystagmus, it's a central nystagmus. So the second point is I told you, like the velocity is the peripheral nystagmus, the velocity is great when you look at the quick beating side. But the central nystagmus, on the other hand, does not conform to this particular Alexander's law. Now we'll see what happens in a central type of nystagmus. So this is a central one. Look what happens. So when the patient looks at the left side, patient has nystagmus, and then left side, it's left beating. Now the patient looks at the right side, and it's right beating now. So it's direction change in nystagmus. Now this is never going to happen in a peripheral vestibular problem. The peripheral vestibular problem, it beats to one side, just to one side. So it beats to the opposite side or away from the affected side, and it becomes more prominent when you look at the fast beating side. Now this is not that case. This just when you look at the right side, right beating, look to left side, left beating. So it's direction changes. This is definitely a central sort of nystagmus. So we are now coming back to our problem. Now we have a single big episode. Patient has got admitted to a casualty ward, and you all examine the patient. So you just need to make sure it's peripheral or central. So you know, now you look for peripheral vestibular nystagmus. So if you find peripheral vestibular nystagmus, well, it's peripheral. If we find central signs, the central nystagmus, then it's central. And there's another test called head impulse test. We'll come to next. Right. So head impulse test, it's sort of a recently described phenomenon test. So once again, it check your integrity of the vestibular system, vestibular ocular reflex. So you know the vestibular ocular reflex, and the vestibular ocular reflex can be there in horizontal plane as well as vertical planes, because you have other canals. But when you move your head, the eyes remains on a focus. That's for you to keep the visual field stable when you move around. Otherwise, you will feel the visual field also moving up and down, which is a very difficult scenario. So here, a patient is looking at you. You're asking the patient to look at your nose, and then you thrust the head. The patient can still see, or patient can still keep the eyes focused on your nose. So eyes doesn't move. That is a normal head impulse test. So when you move your head to, or when you thrust your head to one side or the other side, you can keep the eyes focused on to the patient's, whatever the focal point. The eyes doesn't move. Whereas when it's abnormal, the second one, now when the patient's head moves, the eyes also moves. The eyes also goes, and then the eyes come back with a saccade. It comes after a while. Eyes moves with the patient's movement and then comes back. So this particular defect is there on the affected side. So if you see this, the right side is abnormal, left side is normal. Right side, right movement, yes, it comes back. It comes back after a while. Have another look. Yes, it breaks on the right side. So this is a positive head impulse test, which is abnormal head impulse test due to right-sided vestibular failure. So in this patient, if you have a failure, the patient will have right-sided abnormal head impulse test, and the nystagmus, if it's there, it should beat to the opposite side. Nystagmus should therefore it should beat to the left side. I'll just play this again for you to try and understand. Yes, catch up there, normal there, catch up, normal. That's broken, obviously. So abnormal head impulse test to the right side. So we know now positive head impulse test and the peripheral vestibular nystagmus. When you have those, we know it's peripheral. And there's another third test called skew deviation. I'll just show this. Now, basically, you need to do what's called cover test to cover the eyes. So eyes goes up and down. It goes up, down, up, down. So look at what happens with alternative cover test. One eye goes up and then the other one come down. This goes up basically. Sorry, this goes up and the other one comes down. So I'll play this again. So this is called skew deviation, which is a central sign. Now, this happens due to a central problem in the pathways of otoliths. I'll discuss about otoliths later on, but just forget those things for the time being. So what I'm saying is, now when you have all these three, like peripheral vestibular nystagmus, positive head impulse test, and negative skew deviation, you're 100% sure that it's almost 100% sure that it's peripheral, and you don't have to even do an MRI scan. You can rule out central pathology and you can make sure that it's central. So this is called hints. It is head impulse, hint HI head impulse. N is nystagmus, this is nystagmus, and TS is test of skew. So when you have hints positive, or it can be one or the other, you're 100% sure that it's peripheral or the central on the other hand. Now, there's another important point here. Now, when you diagnose peripheral vestibular problems, sometimes there is a confusion whether it's vestibular neuritis or labyrinthitis. So those are two common problems that we see in ENT or peripheral practice. So now vestibular neuritis is purely a vestibular problem. There's no sensorineural hearing loss. There's no hearing loss, and therefore there are no tinnitus. It's just a problem in the vestibular nerve. But in acute labyrinthitis, you have sensorineural hearing loss. Labyrinth is the whole system, like vestibular system and the cochlea. So therefore, we have tinnitus. You may have tinnitus. So that's the distinction between vestibular neuritis and acute labyrinthitis. So therefore, you need to do a hearing test, usually pure tone audiogram, for you to diagnose acute labyrinthitis. Now, how to treat? Now, this acute unilateral vestibular failure, whether it could be due to vestibular neuritis or labyrinthitis, is a vestibular failure. So one acute unilateral vestibular failure. So one side gets failed, and it recovers by compensation. Initially, you have what's called static compensation, where the patient, the brain recovers even if the patient doesn't move. So during that period, usually patient is on a bed. It's a very, very sort of severe period. You might have to administer some fluid. Sometimes you might have to give some vestibular sedatives like procoprazine or cinracine. And if you suspect central abnormality, you might go for MRI scan urgently in that period, but it usually lasts for about 5 days. Now, after day 5, you get a period called dynamic compensation, where the patient need to be moved, patient need to get up from the bed, and patient need to start rehabilitating exercises. So you have to stop vestibular sedatives at vestibular suppressants at that point, and then encourage patient to do rehabilitation exercises. So there have been a lot of questions about vestibular rehabilitation exercises. Now, basically, these exercises, now I'll tell you what they are. Now, if you don't do exercises, what happens is now this is the normal patient, good balance, and the patient loses balance all of a sudden due to vestibular failure. And then if you don't do exercises, the patient is never going to get normal balance. Patient is never going to get normal balance. But if you do exercises, sometimes you might have decompensatory phases, but gradually the patient is going to have normal balance. So the other side and the brain compensates for whatever the loss. So vestibular rehabilitation exercises are therefore extremely important to manage these patients without giving more and more vestibular suppressants. So vestibular suppressants are there only for about 5 days during the static compensatory period. Now, vestibular rehabilitation exercises are aimed to improve vestibular ocular reflex and vestibular spinal reflex. Now, there's another reflex like vestibular ocular reflex, there's a vestibular spinal reflex, same sort of thing for you to have normal balance and the normal eye movement. So you just need to improve these. I'll just show a video clip animation. So this is to improve eye movements. So you look at one and then move left and right, up and down. You improve in the vestibular ocular reflex slowly. You start slowly and then you increase the speed. So these are called vestibular ocular reflex exercises. You can initially do the sitting position, then you can stand up and do them. It will be more difficult now. So you're looking at one particular point and then move the eye, move the head left and right. So you are trying to stimulate different canals, lateral canals and then the superior and posterior canals. Then you start moving. This is to improve your vestibular spinal reflex while you're doing those head movements. So these are there in YouTube. So different exercises are there, but more or less it's basic to improve you're now working on a uneven surface. So the principle is for you to improve your vestibular ocular reflex and the vestibular spinal reflex. This is tandem walk. So the important message is acute unilateral vestibular failure. Treat initially with drugs, vestibular suppressants to relieve symptoms. And once that phase is out, then you will have to actively rehabilitate these patients. Otherwise, they are going to have what's called chronic dizziness, which we will discuss later on. So now we discussed a single episode. So yeah, now we'll come to multiple episode, which is the commoner form, the commoner pattern that we see in our clinics. Multiple episodes. A history: a lady comes to your clinic with history of vertigo, and she has experienced several times during the past 1 week. So several episodes, multiple episodes. It's clear, and it's vertigo, it's rotatory thing, and then multiple episodes. Now I'm going to ask you a question. I don't know whether it's possible to get an answer from someone, because it's otherwise going to be boring. So when you have a patient with multiple episodes and you know it's vertigo and you know it's multiple, and what's going to be your next question? Yeah, can you just type in the chat box just to see whether we get a answer?
No, sir.
Is anyone hearing? Nothing about there are how many participants? 190. Okay. Can someone just type your answer? Now, a patient comes to you, your clinic or wherever, or practice with multiple episodes. Can you see anything? How many hours? How frequently? Yes, those are important. Neurologic, how frequently, regular or not, hearing loss. Yes, we get a after getting from bed. Yeah, I think yes, I think the time is important. Yeah, the associated hearing loss is important. Yes, but more, I think, yeah, whether it's positional. I think I got the answer. So what I would ask is whether it's positional or spontaneous, because this makes the basis of our understanding. Because the positional vertigo is so common, Bpv is so common. Bpp is the commonest form of vertigo syndrome that we in our clinical practice. So we just need to rule out Bppv because it's very common. Now, always now you understand. Now we don't take very detailed history all the time. Now, when it's required, we go for detailed history. Now, even in the first case, we saw it's a big episode. We know it's a big one vertigo, not this one, the last scenario. And we just jump into examination. We examine for head impulse test, we examine for nystagmus, and we did some neurological examination to make sure the patient has central or peripheral. So we didn't go into all these past history. I know you can go later on, but we didn't go because now we have a limited time always, especially in the clinic. Now, when these patients, the second scenario, these patients come to your clinic, so you don't have much time to go into detailed history. Now your history might take even 1 hour sometimes. If you take proper history from a vertigo patient, it's very difficult. You probably would have experience. So I would just narrow down and ask whether those are spontaneously occurring ones or positional, and I'll try to select the positional patients. Now this is one of the studies that we've done in Anuradhapura. See the prevalences, like the Bpv is the commonest form, about 30%. The vestibular migraine, once again, it comes as a episodic vertigo, and the Meniere's, those are the common things. Now unilateral failure and labyrinthine failure, those are less common, right? So the episodic vertigo, the Bpv, has to be isolated first and treated. These are the common forms, right? So multiple episode, when you see a patient with multiple episodes, if you are sure that it's vertigo and if you are sure that it's multiple episode, you need to ask whether it's positional or spontaneous. So we'll now, once again, don't try to confuse positional and postural vertigo. Now, for example, there was a question, I think I asked someone beforehand. Now, whether a patient with migraine could have a vertigo during head movement. Yes, or a patient during a migraine attack, sometimes patient just can have headache or headache with vertigo or without vertigo, or sometimes you can have just vertigo without headache even. During that episode, the patient will not like to move the head because the patient has postural vertigo. And even in the previous scenario that we discussed early, like acute labyrinthine failure, acute vestibular failure, the patient also will, I mean, he won't, he or she will not be able to get up even. They don't like to move their head. So this is because of posture. Any vertigo will have postural changes. So posturally, it will get activated. Now, that's not we are going to discuss now here. This is positional vertigo. Positional vertigo is you have a vertigo in particular head movements. When you probably lie down, when you try to lie down, or when you get up, or when you turn over to one side or the other side, or during particular positional changes only you get vertigo, and it's very sort of a short lasting thing. So you need to try and understand this distinction between postural and positional vertigo. Now, benign paroxysmal positional vertigo is not postural. Benign paroxysmal, it's a benign condition, so it's Bppv. Therefore, benign paroxysmal positional vertigo is the commonest form of vertigo that we see, as I already told. Now, how this happens, why you get vertigo and why you get this nystagmus. Now, these patients will have nystagmus during positional testing. Now, once again, now here there's no paralysis. There's nothing called paralysis. There will be impulses here, but there will be some hyperstimulation due to some reason. Now, in this case, in Bppv, the hyperstimulation is, as we are going to discuss, is some fallen otoliths in the canal. So they will, pull or push the crista here, causing abnormal movement. Like you get the same nystagmus, you get the same vertigo, and when you have nystagmus, you get vertigo because you have abnormal eye movement. So this is due to stimulation. So stimulation of the affected side. So when you stimulate one side, the nystagmus will be to the affected side. Now we'll try to understand the pathophysiology of Bppv. Now we need to discuss a bit of the other part. Now we are going to discuss the vestibule. Now the vestibule has what's called the vestibular part of the vestibule has utricle and saccule. Now they have got a different type of sensory organs. They are called maculae, not cristae. They are maculae. More or less same. You have hair cells, you have gelatin, but on top of gelatin you have some otoliths. They are gravity sensitive. So therefore that will detect your tilt, head position or head movement, tilt, as well as it detect your linear acceleration on horizontal plane as well as in vertical plane, like going on lift or maybe car. So its acceleration, deceleration will be detected by these gravity sensitive otoliths. Now those otoliths are there only in utricle and saccule, mainly in the utricle. Now what happens is we will try to understand now the posterior canal Bp. Now posterior canal Bp is the commonest form because the posterior canal is in a more dependent position. It's posterior, yes, but it's inferior as well. So the otoliths usually, because of gravity, it usually falls into posterior canal when they are dislodged from the utricle. So now for you to understand posterior canal, you need to understand a bit of the orientation of posterior canal as well. Now these are the lateral canals. These are in the horizontal plane. The posterior canals are here. This is posterior, this is posterior. So so posterior canal, for you to get into horizontal plane or the vertical plane, you need to get the head into one side or the other. So this is left posterior canal now coming into vertical plane. Initially the right posterior canal came into vertical plane. So we'll see what happens. Now the posterior canals along with the superior canals, they also act as these lateral canals. Now these are the lateral canals, two lateral canal in the horizontal plane, but in a vertical plane, posterior canal, right posterior and left anterior, they act as a pair. So it detects your vertical movement in that plane. So now, however, those muscles which are responsible for eye movements are not attached exactly to the equator. So these oblique muscles and even the subrecti are not in the, they are not like your medial and lateral recti. These are attached a bit obliquely. Therefore, when you get nystagmus, the nystagmus is going to be a bit rotated. It's not going to be purely horizontal. So this is the posterior canal. There's a posterior canal, that posterior canal on the right side in a normal sitting patient. Now these are the otoliths. Otoliths are here. They are normal in the position. They are in the vestibule. So we'll see what happens. The patient lies down. Again, it's normal. They are still in the vestibule. But for some reason, maybe trauma or infection or some other reason, they fall into one of those canals, and it's going to be the posterior usual because it's dependent. So now this is abnormal. So we'll see what happens when the patient gets up. When the patient gets up, these crystals slowly come down, and that will cause abnormal stimulation of the vestibular apparatus on the cristae on the affected side, and that will therefore induce some nystagmus, and nystagmus means vertigo. So when the patient lies down again, what happens? Patient lies down, they also fall. So that will deviate the cupula to the opposite side now, and you get nystagmus to the opposite side. So this happens when you get up, you get nystagmus. When you lie down, you get nystagmus. So if you don't see nystagmus, you might see even vertigo even. So this particular test is called Dix-Hole pipe test. Now, exactly this is what we are going to do now, and it's for posterior canal Bpp, not for other canals. Now there are other canals. You can get Bpp on the other canals, which are very rare. Posterior canal is the commonest one, and it's diagnosed by Dix-Hole pipe test. Now this is how you do it, to make the patient lie down on a head hanging position. Now once again, have a look at those otoliths here. So look what happens to them. They also come down. And the posterior canal is the commonest variant. So this is how we do. You rotate the head to one side and then get the patient into a head hanging position for you to get the posterior canal into dependent position. So this is how I have been doing it. Head up and then get the patient down, and you look for nystagmus. You open the eye and look for nystagmus, and you need to normally wait for about 30 seconds to develop nystagmus, because there's a latency, because the otoliths take some time to come down. So you get nystagmus. With the nystagmus, you get vertigo, and the vertigo usually increases and then decreases, and it settles, it adapts, and it reverses when you get the patient up again. Sorry. So this is the nystagmus. Because of these oblique muscles, you get a sort of a upbeating and a torsional nystagmus, and the rotation is to the affected side. And in this case, it's a right-sided one. So you don't get, if the problem is on the right side, you get this type of nystagmus to the right side, but not to the left side. So I'll have another look. So you have upbeat and a torsion. So when it's there, and you're quite sure that it's Bpvc. And it, yeah, that's a nystagmus. You see the upbeat very well, and it comes after a while, and it settles, and you see the rotation also, upbeat and rotation. In this case, it's to the rotation, it's to the right side. If you see it carefully, I'll show it, play it again, and then rotation, it's to the right side. It has to be the right-sided problem. You are just seeing one eye here, a recording of one eye. Sorry, this is rotation is to the left side. Sorry, I think, yes, yeah, this is the left side. So rotation was to this side. Now the Bpvc, when you do whole pike test or the positional test, these are characteristic features. Now it comes after a while. We have a latency, and then it increases crescendo, and then it decreases decrescendo, and then it adapts, settles, and it reverses when you get up the patient, or when you do the opposite position, you get reversal. And then when you keep on doing this test, you can't do this test for 10 times. When you do a few times, it fatigues, because the otoliths go here and there, and then you get a sort of a fatigability therefore, and you need to wait for 1.5 hours to do the test again to get it positive result. So how to treat? It's quite simple. Now you don't treat with drugs for these patients. So when you diagnose, now this is the same patient. So you have this otoliths. Now the patient is lying down. This is Dix-Hall pike test, and you see nystagmus now, because the patient has just lied down, and then otoliths have come down. You get nystagmus. So you need to get those otoliths into the utricle. So what you need to do is, you need to get the patient upside down. So theoretically, otolith should fall down, and normally when it's fall down in the utricle, it settles. Normally when you keep for some time, it settles, because of not the reason, but it settles. But you can't do this. You can't make the patients upside down in the clinic. So there's a different menu. Now have a look. Now this is the posterior canal, the red one, and these are the otoliths there. So what we can do is, we can do the same thing by doing a different maneuver. This is called a Plea maneuver. So you get the patient into Dix-Hall pike position like initially, and then turn the head to the opposite side 90 degrees, and then some 90 degrees, some more, and then get the patient up. So when you do that, if you look at, they will usually, those results have come down. They are coming to the they have come back into the utricle. So this is how you do a Plea maneuver. You have a patient, the patient's problem is on the right side. You get the patient to do the Dix-Hall pike test, or do the Dix-Hall pike test. and you wait for the nystagmus to settle. And this nystagmus is not the typical nystagmus that we its animation is not very good. You get upbeating and torsional nystagmus to the right side if it's a right-sided problem. Turn the head 90 degrees from the start to the opposite side while the patient is in the head hanging position, and another 90 degrees after about 1 minute. So you keep one position in one position for about 30 seconds to 1 minute, and then another 30 seconds, and then get the patient up. So when you do that, you get those otoliths coming into the proper position if it is due to posterior canal Bpv. Now this is for posterior canal Bpv, not for other canals. I'm not going to discuss other canals because it makes everything confusing. Other canals are less common. So now we know we have discussed the single episode. Now this is multiple. We know the multiple episodes can be positional or spontaneous. The positional ones are Bpp, but very rarely positional vertigo can be due to central. Now, for example, if you don't have those typical features, now typical features of Bpp are like, we have latency, you have crescendo, decrescendo, and then adaptation, fatigability, and those things. So if you have a patient, when you do a positional test, if you have nystagmus which keep on beating without any adaptation, that could be due to central posterior fossa pathology. Sometimes cerebellar pathologies also can cause nystagmus, even migraine sometimes. But those doesn't conform to the typical features of Bpp. Typical Bpp will have typical nystagmus or vertigo features. So those are latency, crescendo, decrescendo, adaptation, fatigability, and the reversal. Okay, so now we are coming to the spontaneously occurring vestibular vertigo or episodic vertigo. Spontaneous. Now I told like the episodic vertigo could be spontaneous or positional. Now positional one we have discussed, which is Bpv. We have discussed posterior Bpp. Now vestibular migraine, Meniere's, vascular events like transient ischemic attacks, vestibular paroxysmal, episodic ataxia. And don't think about these things too much, but probably I think migraine and Meniere's are more important. Those are the common forms. Are spontaneously occurring. When the patient is just sitting down, they get attacks like migraine attacks, headache, Meniere's attack with the ear symptoms. So we'll just see what happens in Meniere's. Now, just for you to understand one thing, now this is a cross section of a cochlea, not the vestibular part. So cochlea has three compartments. You have perilymph and endolymph. So look what happens to the endolymph. Now sometimes this endolymphatic space swells up. This space swells up. That's called endolymphatic hydrops. It happens for about usually half an hour to 1 hour or several hours. So it becomes swollen up, and this membrane ruptures, and then that will make some electrolyte imbalance between the endolymphatic and perilymphatic space, and that imbalance will cause abnormal excitation of the nerves, and then nystagmus and vertigo, and then it heals. You get sort of micro perforations, and it heals within about a couple of hours sometimes. So usually you get vertigo attacks lasting for about half an hour to few hours, and it settles and it comes back again. So now this is, as I told you, this is cochlea. So you get hearing loss also, along with now the same compartments are there in the vestibular apparatus also, same cerebral canals and the ventricle saccule. So you get sorry, in Meniere's hearing loss as well as vertigo. So episodes of hearing loss with sometimes tinnitus, and then vertigo, which lasts for about half an hour to few hours. Now I told you this because now history becomes very important. Now for you to diagnose Meniere's, you need to have this particular history. So it duration, once again, like minutes to hours. It's not going to be few seconds, definitely, because it takes some time for this process to happen. And then it's always associated with oral fullness, fluctuating hearing loss, like hearing loss, hearing goes down and then come back. So you have these symptoms. Now we are coming to the importance of history in these patients. So you take a sort of a detailed history when a patient is having a spontaneously occurring episodic vertigo, but not in BP patient. The BP patient, yes, you need to take a history of, you need to know whether it's vertigo or not, and whether you need to know whether it's a position or not. And then you do whole pipe test and cure the patient, settle the patient problem. But when it comes to these problems, you need to go back and sit down and take a sort of a better history. Now, once again, migraine, the second one, you have associated headache usually, or photophobia or phonophobia, or you might see aura, or it can be triggered by sleep deprivation, food deprivation, or cheese, chocolate, nuts, and things like that. So now sometimes you can have vestibular migraine without headache. That was one of the questions asked by you. But still, then you have a trigger. You might have aura, photophobia. So you know it's migraine. It's not migraine, Meniere's. So it's very easy to diagnose when you take a good history. And TIA, transient ischemic attacks, you might have other brainstem symptoms like amaurosis, phobiac. So sometimes dysphagia, dysarthria, or some sort of a transient other neurological symptoms. Now, vestibular paroxysms and other things. Now, vestibular paroxysms is a condition where you have, it's like trigeminal neuralgia. You have a cross compression between the 8th nerve complex and the anterior inferior cerebral artery. So because of that, you get sort of paroxysms, very short lasting vertigo, but spontaneously occurring one. They are not positional. Episodic ataxia is a neurological thing. It's ataxia, it's not vertigo, because it can sometimes mimic. And even panic attacks are not really vertigo, but they might say it's dizzy. But they comes in episodes, but panic attacks will have other psychological like symptoms like anxiety, avoidance, or other autonomic symptoms. Anyway, the history, what I'm trying to elaborate is that, emphasize is that the history becomes very important when it comes to spontaneously occurring episodic vertigo. Now, how to treat? Now, Meniere's is typically treated with beta histine and hydrochlorothiazide. Beta histine seems to be effective in Meniere's. Vestibular migraine is treated with anti-migraine treatment like propanolol or fluorescein or those anti-migrainous agents. Vestibular paroxysmal, like we treat trigeminal neuralgia, we treat with carbamazepine. Episodic ataxia is neurological. They are responsive to acetazolamide. Okay, so we know this diagram. So we can have vertigo. It could be single episode. Single episode could be central or peripheral. How to differentiate? By looking at the nystagmus, by looking at the head impulse test, and by looking at the skew deviation. If you diagnose peripheral could be due to labyrinthine failure, which will have hearing loss, or vestibular failure, just vestibular neuritis, which will not have hearing loss. Then you have multiple episode. The first question is whether it's positional. If it is positional, it's usually due to Bpv, it's usually due to posterior canal. But rarely, if it doesn't have typical signs of Bpp, it could be due to a central thing where you will see the difference definitely. And the multiple episodes could be due to spontaneously occurring episodes like migraine, Meniere's, and some other neurological problems. So apart from those, you have what's called chronic dizziness. This is the last bit. Sorry. Now, because someone wanted to have a bit of a pediatric cases. Now, basically, pediatric cases are also same as adult cases, but the terminology could be slightly different. Now, there's a condition called Bpvc, benign paroxysmal vertigo in childhood, Bpvc, now which is equivalent to migraine in children. Basically, those who get these episodes of vertigo, the patient, just children, like they are in the age of 5, 6, 7, they get episodes of vertigo, and then when the episode passes away, the patients are completely normal, and they might have headache, associated headache, and these patients usually later on in the life they develop migraine or vestibular migraine. And you can also have Bpv in children, and you can also have vestibular failures like acute labyrinthine failure, perhaps sometimes due to trauma, fractures, maybe vestibular neuritis. You can have the same but Bpv is something that we see commonly in pediatric cases and treated by propranolol or anti-migraine medication, and it settles usually. It has a benign course once again. Of course, when you have these patients, the pediatric neurologist would do EEGs and sometimes MRI if required. So we are coming to the last part of the talk, chronic dizziness. Once again, another scenario. A patient complains dizziness for months. It's been going on for a few months. And the patient says the patient is dizzy when he is moving the head, when he is looking left or right, patient gets a bit dizzy. It's not really vertigo, it's just dizziness. You can't see a sort of rotatory movement. And the patient gives a past history of hospital admission, which is an acute severe episode of vertigo sometime back. And the vestibular examination is completely normal. Now, these are the patients who are going to be very difficult candidates, very difficult to assess. You might have to take good history. Now we got this history of having a hospital admission, and it's not really vertigo. It's more or less a problem with the spatial perception and normal vestibular examination clinically. Now these patients need a bit of sometimes vestibular investigations. Now here is one of our patients who have had what's called caloric test at Anuradhapura. Look what has happened. Now what we do in caloric test is that's the same patient. What we do in caloric test is we irrigate the ear canal with warm and cold air or water. Now when you irrigate the right side with cold and right side with warm air, in this case this is air calorics, so you get nystagmus. These are the nystagmus events. They are collected, they are diagrammatically represented, but it doesn't happen on the other side. So the left side, it doesn't happen. So the patient, we diagnose this patient this particular patient having at this point the patient would have had a severe vestibular failure that would have got like probably I think that wouldn't have been treated properly by vestibular rehabilitation. Therefore the patient is now in a chronically dizzy state. So when you don't treat, when you don't rehabilitate those patients with vestibular failure, they will lead to what's called this overly compensated unilateral vestibular failure. For you to diagnose these things, you need to have vestibular investigations. This is one, calorics, or you can do head impulse test also in a objective manner, which is called VHIT, video head impulse test. Head impulse test, VHIT, video head impulse test. Basically, you do this head thrust multiple times, and then you collect those data and get the diagrams like audiograms. So you need to have video investigation sometimes for you to diagnose these chronically dizzy patients. Now, as I told you, sorry, prolonged vestibular suppressants are not good for vestibular failure patients. They are used only for 3 to 5 days. So vestibular neuritis or labyrinthitis, you need to make sure the patients are going to get rehabilitated very well with vestibular rehabilitation exercises. Another case, a man complains of severe imbalance. Severe imbalance, this is basically imbalance after course of amikacin. It's vestibular and auditory toxic given for some renal problem. And the imbalance is worse in darkness. Imbalance. So when you close the eyes, the imbalance is worse, and patient has what's called oscillopsia on walking. When the patient's walking, the patient can see the environment moving, something like this. So it's going to be a very difficult condition for patient. When the patient moves, the oscillopsia, patient moves, when the patient walks, the patient feels everything is moving. This is due to, now this is the same patient. This is a real patient. I got the permission to get this video clip. So we'll see what happens. The patient, we are doing head impulse test in this patient. Sorry, head impulse test. It's positive on both sides. Right side positive, left side also positive. You have catch-up circuits on both sides. So the patient has problem on both sides. So this is called bilateral vestibular failure due to drug toxicity. The patient finds it very difficult to walk. When the patient walks, the patient see everything is moving. It's a very difficult condition. So this is a caloric test of a patient. So you can't elicit nystagmus by irrigating cold or warm air in this patient on either side. A very difficult condition to rehabilitate. Still, you are going to rehabilitate this patient. There are exercises which is beyond this talk, but very difficult to rehabilitate these patients. Lastly, some patients with vestibular problems, say structural vestibular problems, you have Bpp or you have unilateral vestibular failure or migraine, you don't treat them properly. Therefore, they go into a different stage. Now, this happens especially those who have got bit of a psychological predisposition. Now, some patients have personality traits and anxiety disorders. So those patients will go into a sort of a different phase, which is called a functional problem, PPPD. So that is triple PD, persistent perceptual postural dizziness. Basically, you get ups and downs, but you're chronically dizzy, and they say they can't get up and walk. They can't. The movement makes their problem worse, and then and they are obviously anxious. They have personality problems. If you go back to the history, they might give a good history of Bpv or something. It's a reactive problem due to your poor coping with your vertigo, and the patient hasn't been given enough reassurance or even enough rehabilitation or whatever the reason. So it's a bit of a difficult condition to get the patient back to the original position. So that's all about it. I think we have about another, it's almost time, isn't it? Thank you. Can entertain few questions if you have, but I got those questions beforehand, so I have tried to answer all the questions in the talk, and the recording will be anyway available, so you can slowly go through later on. So I mean, sometimes it could have been a bit complicated, but if you go through once or twice, then you'll understand these things. Thank you very much.
Thank you very much, sir, for your excellent, very informative lecture on practical approach to vertigo and dizziness. We have a few questions today. First one, Plea Manual.
Plea Manual.
Yes. How frequently do it?
Yes, now we do, there's no frequency as such. Now, usually, if you do a plea properly, you can treat the patient then and there, even by once going. But if it doesn't settle, you might do again, and you can do it again and again. There's no problem. There's no end to it. As long as it's there, you can do it. As long as you're sure that the diagnosis was taken at Bpv. So usually it's just once. So if you do it, diagnose properly, and then do the procedure once, it will settle the problem if you do it correctly.
Next one is vestibular neuritis, labyrinthitis followed by upper respiratory tract infection.
Yes, not labyrinthitis, but vestibular neuritis is known to follow upper respiratory infections, viral infections, like any other neuritis.
In Moni's disease, hearing loss is permanent?
Many years, no. Many years, during those attacks, you get hearing loss, and then it recovers. But the patients will get repeated attacks. So with repeated attacks, gradually patients' hearing goes down, and even the balance goes down. So chronically, if you have sort of frequent manias and chronic manias, the patient's balance on that side goes down, and the hearing also goes down slowly.
Okay, sir. Thank you very much on behalf of GMOA and Sri Knowledge Academy for giving us an informative morning. Thank you all participants for joining today's session, and find the link in the chat box for applying e-certificate for participation. We appreciate your feedback to improve further webinar also. This lecture will be available to you on Sri YouTube channel. You can go through it at any time to cover up any missed part to fix your knowledge. Thank you.
Thank you very much.